Thank you for joining this lecture entitled Overview of Neuromuscular Disorders. These slides are from Diana Sela, but I'll take you through this topic. Ideally, it's supposed to be maybe more of a focus on common peripheral nervous system conditions more than neuromuscular, because I'll touch on topics that are not really sort of neuromuscular. Yeah, so the presentation itself will be via sort of some case scenarios to help us with the discussions, and then we'll go into the actual sort of meat of the topics that the scenarios are depicting. So the first scenario is a 29-year-old man with no significant past medical history who was HIV negative, who presents with a 4-day days of progressive numbness and weakness of his legs. So when you have such a scenario, of course, you're asking yourself, what more information would you sort of want to know about this patient? And of course, as a rule, when you're getting your history, you want to make sure that you go through the elements of the history from the presenting complaints through asking questions that are pertinent to sort of help you figure out whether the progressive lower limb weakness with numbness is potentially peripheral or sort of central. So you have to ask about onset, you have to ask about evolution of this weakness. Did it start distal and then progressively sort of evolve upwards? And in reality, all these questions that you are asking are sort of tailored towards trying to give you an indication of the hypothesis with regards to localization of his problem. And in this case, you have to think about localization first before you can think about your differential diagnosis, because a problem in the peripheral nervous system versus a problem in the central nervous system might translate into a completely different sort of differential diagnosis. And this is very important as you go through your history in terms of your HPI, your review of systems, your past medical history, surgical history, your drug history, your family history, as well as your social history. All those things that you're asking through these different sort of aspects are important to help you to sort of localize, so that at the end of your history, you are able to formulate a proper sort of localization before you get into your examination, so that you use your examination to help you to really see whether you're on track in terms of what you're thinking about from your history. So in terms of the case presentation, the mental status, language, parietal function were normal, and then cranial nerves were normal, and then motor, bulk, and tone were normal. Strength was 5 out of 5, bilateral in the upper extremities, and then 4 out of 5 at hip flexors, knee extensors, knee flexors bilaterally, and then 3 out of 5 with dorsiflexion and plantar flexion bilaterally. Reflexes were 2+. In the biceps bilaterally, 1+ at triceps, and brachioradialis bilaterally, and absent in bilateral lower extremities, with toes which were downgoing. And then sensation was decreased to all modalities from feet to knees, and coordination was normal. Gait was a foot slapping gait, difficulty with walking on toes and heels. So what would potentially be your localization on the basis of that exam? And bearing in mind that you have to connect the exam with your history, what are the important elements that will help you with localization? So you have to remember from the scenario that Of course, you have progressive lower limb weakness over a 4-day period. And then you've done an exam which is suggestive of predominant distal weakness in the lower extremities with absent reflexes and a stocken sensory distribution. So the most important thing, of course, when you look at such a pattern is the fact that when you're getting a sensory distribution which is token in nature, that tells you that potentially what you're dealing with could be a lower motor neuron lesion problem more than an upper motor neuron lesion problem. And again, you have to go into these aspects in terms of sort of your tone and relate it to the patient before you. You have to look at, for instance, our patient had reduced tone, and that would be a feature of the lower motor neuron lesion as opposed to spasticity, which is an upper motor neuron lesion pattern. And then muscle bulk, of course, over time, in the lower motor neuron lesion, you get atrophy, whereas in the upper motor neuron lesion, it's sort of normal. Similarly, you get fasciculations in the lower motor neuron lesion problem, but not always. And then, of course, there are no fasciculations in upper motor neuron lesion problem. And then the pattern of weakness is also very important. In a lower motor neuron lesion problem, you get a proximal distal gradient where you get more distal weakness than proximal weakness. Whereas for an upper motor neuron lesion problem, you get predominant extensor weakness in the upper extremities and flexor weakness in the lower extremities. And then with reflexes, of course, they are reduced or absent in the lower motor neuron lesion problem. And then they are sort of increased in an upper motor neuron lesion with downgoing toes in the lower motor neuron lesion and upgoing in an upper motor neuron lesion. Of course, it has to be emphasized that when you have injury, particularly to the spinal cord and in an acute setting, in the phase of neurogenic shock, your features that are upper motor neuron require time to sort of evolve to being what is highlighted in this table. So again, with lower motor neuron lesion sort of problems, and particularly the peripheral nervous system, you always have to remember that, of course, in terms of your localization, you have to think of it in terms of from the sort of roots all the way up to the muscle. And generally, when you look at the root injury or root problem, you get a loss of sensation or weakness, which is of a radicular distribution. Whereas for specific nerves, you get loss of sensation in a dermatomal distribution, and then you get weakness in named nerve distribution. And this generally tends to be asymmetric. So an example is, for instance, a sciatic nerve sort of injury, you get predominantly distribution of injury or weakness, which is consistent with the sciatic nerve supply. And then for a peripheral nerve or a polyneuropathy, you get a glove and stocken distribution if both the upper limbs and lower limbs are affected. If it's just the lower limbs that are affected, you get a stocken distribution. And then for a neuromuscular junction problem, you get sort of symmetric involvement, and generally tends to be proximal more than distal. In the upper limbs, you're talking about involvement of the arms, shoulders, whereas in the lower limbs, you are talking about involvement more of the thighs and the pelvis. And then you get fatigability depending on the neuromuscular junction problem you're dealing with. And then you can also get bulbar and ocular symptoms or involvement. And then with a muscle problem, of course, it tends to be symmetric, and similar to the neuromuscular junction problem, tends to be more proximal than distal. So getting back to the case that was highlighted, your differential diagnosis, of course, in that case would be potentially something that is in the peripheral nervous system more than central nervous system, and you would entertain something like a Guillain-Barré syndrome or an acute inflammatory demyelinating polyradiculoneuropathy or AIDP. you might entertain a chronic inflammatory demyelinating neuropathy. Of course, bearing in mind that the symptoms in the scenario were only for 4 days and not knowing what time course would sort of be required for evolution of symptoms to sort of getting to peak position. An acute myelopathy would be entertained on the basis of what I had mentioned earlier, that when you get neurogenic shock, particularly in the acute setting, you are not going to get overwhelming upper motor neuron features, because usually within up to about a week or slightly over a week, you might actually get lower motor neuron features in a setting of injury to the sort of central nervous system. HIV infection, paraneoplastic neuropathy, and polymyelitis might be other things that you sort of want to entertain. But for purposes of our discussion, I think let's focus more on Guillain-Barré syndrome. So Guillain-Barré syndrome, or AIDP, is an autoimmune disease and generally tends to be a post-infectious process with a bunch of organisms sort of attributed to this disease process. In terms of bacteria, you can think of Campylobacter jejuni, and usually classic presentation is an episode of diarrhea prior to onset of neurological symptoms. There are viruses that are implicated, including dengue, Zika, chikungunya, HIV, and of course, COVID as well. This, of course, may also occur as a consequence of a systemic stressor, like, for instance, post-trauma, surgical procedure, and even things like vaccination. So sometimes you may have a scenario where the precipitant is actually not clear. In terms of epidemiology, generally it tends to affect men more than women, and the elderly more than children, with an increase of about 20% for every decade of life. In terms of the clinical presentation, generally you get a progressive symmetric ascending weakness of multiple limbs. So you sort of peak in terms of symptom evolution within 4 weeks, although there are some who sort of reach the peak of their symptoms anywhere between 4 to 8 weeks, but generally within 4 weeks, you should have peaked in terms of symptom evolution. And then you get a progressive ascending sensory abnormalities, and these might be sort of numbness, like in the scenario that we were given, but sometimes it could be paresthesias, it could be burning sensation, it could also just be sort of pain. And often, these might be preceded by non-specific sort of lower back ache, and blood and bowel involvement in Guillain-Barré syndrome is actually very rare, so much so that if someone has blood and bowel symptoms, you actually have to start thinking about a potentially cord problem. There are instances where blood and bowel might sort of be affected, like in the setting of autonomic sort of involvement in GBS, and could present with problems there. But generally a rare phenomenon and something where you have to consider potential sort of cord involvement. In terms of your examination, you get loss of reflexes, so you have areflexia throughout with maybe hyporeflexia proximally, and then with symmetric weakness, generally more in the lower limbs than in the upper extremities. And then there might be some sensory loss, which also generally tends to be distal. You can get, like I mentioned earlier, glove and Stocken distribution. And then in terms of investigations, you want to do a lumbar puncture. And on a lumbar puncture, you want to see albumin-cytologic dissociation, where you get an increase in protein, but with no cells. And then you might want to do a nerve conduction study and an electromyography, of course, to look for evidence of demyelination, as well as axonal injury, depending on at what stage the patient presents. So in terms of Guillain-Barré syndrome, can be life-threatening complications, especially with respiratory involvement, because result in weakness of respiratory and bulbar muscles, and it might actually be severe in some cases, requiring mechanical ventilation as well as enteral feeds. I briefly talked about autonomic dysfunction. So autonomic dysfunction is a phenomenon that can occur in Guillain-Barré syndrome and might be evidenced by tachycardia, bradycardia, or arrhythmias. And then a lower blood pressure might also translate into blood and bowel symptoms, like I had mentioned earlier, as well as paralytic areas. Arrhythmias are quite a nightmare in an ICU setting and can contribute to a patient going into cardiac arrest and potentially dying. So these autonomic symptoms or autonomic features of Guillain-Barré syndrome are very important to bear in mind in clinical practice, because they can actually alter the outcome of a patient who's got Guillain-Barré syndrome. In terms of treatment, intravenous immunoglobulin at 2 grams per kg per dose, which can be divided over 3 to 5 days, is sort of the preferred treatment. Plasmapheresis is another option with, of course, up to about 5 cycles of treatment, which might take up to about a week to 2 weeks, is another option. There is no role for steroids in management of a patient with Guillain-Barré syndrome, but more plasmapheresis and intravenous immunoglobulin. And then symptomatic treatment or prevention of complications, such as close cardiopulmonary monitoring to manage arrhythmias, prevent circulatory failure, as well as physiotherapy, DVT prophylaxis, and all other sort of symptomatic modalities are important. When you discuss prognosis, about 5% of patients with GBS will die, and then 25% might have residual neurologic symptoms. But the majority of patients who actually get GBS eventually actually recover, and this accounts for about 70%. There are poor prognostic indicators such as old age, patients requiring mechanical ventilation, and those that have rapidly progressive sort of course over a short period of time. These, of course, will translate into a poor outcome. There are different variants of Guillain-Barré syndrome, depending on what literature you review. There are some of the variants that are listed there. There's the Miller-Fisher syndrome, which sort of starts proximally, affecting maybe sort of bulbar and ocular before involvement of the limbs. Then there's an acute motor axonal neuropathy and an acute motor and sensory axonal neuropathy, which are sort of easier to deal with nerve conduction study in terms of motor and sensory involvement. So the second case we're going to go through is, again, to help us sort of discuss another group of disease entities in the peripheral nervous system. So you have a 75-year-old woman who presents with who presents having recently been treated with ciprofloxacin for a urinary tract infection. She presents with double vision, droopy eyelids, a hoarse voice, and trouble swallowing over the past 5 days. What would you want to know? So again, like the first case, you want to get into your sort of HPI and ask a bunch of questions that are going to help you in terms of localization, of where the problem would be. You want to go into your review of systems, you want to go into past medical history, surgical history, your drug history, as well as your family and sort of social history to help you. So all these things you're asking to help you in terms of localization before you can actually start examining the patient. And this is very crucial, because what you don't want to do is to start examining the patient without having established some sort of localization from the history. When you go into examining this patient, you find that the mental status, language, parietal function is normal. Cranial nerves, there's bilateral ptosis, breathy voice, mild dysarthria as the examination proceeds. And then with motor, there's normal bulk and tone. There's mild proximal weakness of the upper and low, of bilateral upper and lower extremities with repeated testing. And then reflexes, sensation, coordination, and gait are known. Where do you localize the problem? So given the examination findings and the scenario we're giving in the history, where would you localize the problem? So again, you want to think about the features that we got from the examination. So you have to look at your tone. What was the tone in our scenario? Was it spastic? Was it hypotonic? What was the bulk? Was it normal or atrophic? Were there fasciculations present or not? What was the pattern of weakness? If at all there was any weakness anywhere? And then how were the reflexes? How were the toes? Were they upgoing or downgoing? And this is very helpful in terms of trying to figure out from your history and marrying it with your examination, potentially about localization. And then you have to go through this chart and think through again with the scenario that we're given, is it sort of peripheral nervous system or central nervous system? If it's peripheral nervous system, at what point in the peripheral nervous system could the problem be? Is it a root problem? Is it a nerve problem? Is it a polyneuropathy? Or is it a neuromuscular junction problem or a muscle problem? So that's very important for you to remember. And if you go back to the scenario and the examination finding, you actually find that they were more suggestive of a peripheral nervous system problem, and therefore a differential diagnosis would be structured as possibly a myasthenia gravis, a Lambert-Eaton myasthenic syndrome, botulism would be another one that you would entertain. Motor neuron disease, as well as sort of myopathies, would be another sort of entity of things that you would sort of entertain. But for purposes of our discussion, of course, the most likely here is actually a myasthenia gravis, given that we were given 5 days of symptoms. There was a trigger that was highlighted in this scenario where the patient was given ciprofloxacin, and then the patient has a lot of sort of bulbar and ocular symptoms without limb involvement. And that helps you to say, look, if there's something central, you are supposed to be getting limb involvement, because if you remember your brainstem, with all the cranial nerve involvement that the patient has, I mean, you would expect your pyramidal tracts to sort of extrapyramidal tracts to sort of be affected, and then you would get limb involvement. But all that were sort of not there. So myasthenia gravis is really what you're thinking of, and getting into myasthenia gravis. So in terms of epidemiology, myasthenia gravis essentially has two sort of peaks. The first one is in the 20s to 30s, where predominantly females are affected more than males. And then in the 60s to 70s, where males are affected more than females. And of course, the etiology of myasthenia gravis is a block of neuromuscular transmission due to a functional decrease in post-synaptic acetylcholine receptor sort of function. And the blocking is, of course, via acetylcholine receptor antibodies. So in essence, myasthenia gravis is a post-synaptic junction problem where you're getting these sort of antibodies that are binding to acetylcholine receptors and therefore blocking acetylcholine from binding to the receptors. And as a consequence, you end up with, of course, destruction of the complex that is formed, which translates into destruction of sort of receptors. And that, of course, has an impact on how much strength the muscle is able to generate. And he, of course, would explain sort of the weakness. So this is an autoimmune phenomenon. And about 80% are acetylcholine receptor antibody positive, About 15% are muscle-specific tyrosine kinase antibodies. And then there's also your is also your protein 4 or low density lipoprotein related protein 4 antibodies or LRP4 antibodies that are sort of important there, in addition to sort of another subset of small antibodies that are sort of thought to be implicated in this autoimmune process. And then one of the important etiology is the presence of a thymoma, which of course can propagate this process. So in terms of the clinical presentation, so usually is a subacute presentation, usually slow progressive with sort of an insidious onset, maybe masked by systemic infection, medication, and present acutely, like in the scenario we're given where someone has taken ciprofloxacin, and then with bulbar symptoms, about 25% to ptosis, diplopia, 41%, dysphagia, and 10% dysarthria, and 16%. There might also be some nasal voice, trouble with chewing, okay? And then, of course, limb weakness, which generally tends to be more proximal than distal in about 13%. You will get more of upper limb and lower limb involvement in 7%. And patients can also end up with respiratory symptoms with shortness of breath. And then there's a concept of fatigability, which is sort of dependent on activity. So you'll find that these are patients who sort of wake up well, but develop fatigability with activity or as the day sort of progresses, which is very important in terms of nailing down the diagnosis. In terms of examination, of course, you can look at ptosis time, where you ask the patient to sort of look up and try to see if the sort of ptosis sort of gets worse, or you can ask them to blink repeatedly and you sort of see ptosis getting worse. You can ask them to do abduction with the arms several times, maybe up to 10 times, and then test strength. And you'll find that pre them doing abduction maneuvers and post, the weakness, of course, will sort of get worse post-exercise. You can also ask them to do hip flexion. So they can repeat hip flexion several times, maybe up to 10 times. You test the muscle pre them doing the exercise and post, and you will be able to sort of demonstrate fatigability. And then single breath count is another one that, of course, can be useful bedside and sort of help you in terms of them sort of being able to sort of demonstrate fatigability, and you can ask them to sort of count maybe 1 up to 20 in one breath, and you'll see that they'll sort of struggle to do that. In terms of the diagnosis, you can do the Freudian sort of tests or the ice pack test. And the ice pack test, you might sort of focus on the ptosis, where you sort of add, you can put ice in some cloth and sort of ask them to close their eyes, look at the ptosis before they actually do that, and then apply the ice, and then look at the ptosis maybe 5 to 10 minutes after, and you'll see that there will be an improvement in the ptosis with the ice pack. So the idea is that with ice pack is that a reduction in the temperature around the neuromuscular junction actually makes it more efficient compared to an increase in temperature, and that's why there's an improvement in ptosis. And then you can do a nerve conduction study, which will help you in terms of repetitive nerve stimulation. So you want to look for decrement on repetitive nerve stimulation, and you can sort of test sort of different nerves from ulnar to sort of facial nerve around the face, and you will see evidence of decrement, which is sort of a reduction in the CMAP of at least 10% or more. Is sort of positive. And then for for EMG or electromyography, your interest is really to look at single fiber EMG and look for evidence of jitter. So there will be an increase in jitter on electromyography. A chest X-ray and the CT chest is really to look for a thymoma, and then you can do acetylcholine receptor antibodies in the serum, which will be sort of positive in a seropositive myasthenia gravis. In terms of treatment, so really your focus is to see how the patient is presenting. If they're presenting as a myasthenic crisis, you are concerned about respiratory involvement and your aim is to focus on respiratory stabilization. If the patient needs a ventilator, they have to be put on a ventilator. If the patient is not at a stage where they need a ventilator, they need to sort of be assessed. You need a continuous assessment of their respiratory status. And this can sort of easily be done bedside by doing the vital capacity. So you can do a vital capacity and your aim is really to make sure that it doesn't drop below 1 liter or below 15 mils per kg body weight. So you want to make sure that you're assessing that. You can also do arterial blood gases and try to figure out whether the patient is retaining carbon dioxide, because these guys are sort of prone to type 1 respiratory failure. So you want to do those as monitoring to decide whether they need to be on a vent or not. And treatment is really with IVIG or you can do plasma pheresis in terms of a myasthenic crisis. In terms of long-term treatment, you want to avoid medication which can precipitate myasthenic crisis. Beta blockers, high-dose steroids can also precipitate a myasthenic crisis, so much that when you are treating these patients in the acute setting, you want to start them on a low dose of steroids and then slowly escalate the dose. So depending on what sort of works for what different centers sort of do is that they might start at maybe 15 milligrams or 10 milligrams of prednisolone and then increase by 5 on a daily basis on alternate days, targeting reaching a dose of 1 milligram per kg per day dose. So this is sort of your objective in terms of the steroids. So you increase them gradually because they can precipitate a sort of myasthenic crisis. Antibiotics, you have to be very careful. Magnesium is also another one that you have to be very careful about. Acetylcholine receptor drugs, acetylcholinesterase drugs, of course, the most popular one is predostigmine or mestanon, which can also be given to improve symptoms, and then you can sort of add a steroid sparing agent as well, whether it's azathioprine or MMF or cyclosporine or methotrexate, depending on whichever one sort of is available and whichever one you have experience with, can be used in combination with steroids in terms of long-term treatment. There are newer agents like rituximab, which can also sort of be used, or things like cyclophosphamide can also be used in terms of treatment. In the setting of a patient with a thymoma, there is need to do a thymomectomy, or in patients with thymic hyperplasia, particularly those who have refractory myasthenia gravis, can actually have a thymectomy done to sort of increase their response to sort of treatment. Okay, so we move on to case 3, which is a 55-year-old woman presenting with weakness of the right hand, slurred speech, and difficulty walking. So again, what do you want to know? So I've emphasized this point that when you have a scenario like this, you want to go into the HPI, you want to ask as many questions as possible to help you to distinguish between upper motor neuron features versus lower motor neuron features, and trying to sort of figure out where in the axis these symptoms could sort of fit in. And then after you've looked at your HPI, you want to review your systems, and then you want to look at your past medical history, your surgical history, your drug history, your family history, and social history to try to build a case towards sort of localization and potential differential diagnosis. And then once you've done this, you are really looking at formulating a hypothesis about your localization before you start examining the patient. And this is very important because you don't want to start examining the patient without a clear understanding of potentially where the localization of the problem would be, because different localizations would entail a different differential diagnosis. So this patient is examined and the mental status, language, and parietal function are normal. And then in terms of cranial nerves, there's moderate spastic dysarthria, there's tongue fasciculations, and there's mild bilateral tongue weakness. And then in terms of motor, there's prominent atrophy of the intrinsic hand and feet muscles and gastrocnemius muscles bilaterally. There are fasciculations in the right deltoid, pectoralis muscles bilaterally, abdominal muscles, and calf muscles bilaterally. Spasticity in the bilateral lower extremities. Strength is 3 out of 5 in the distal lower extremities, 4 out of 5 in the proximal lower extremities, and 3 out of 5 in the right hand. In terms of the reflexes, there are 3+ in the in bilateral upper extremities and knees, and 4+ with sustained clonus at ankles bilaterally, and then jaw jerk is present, and then left toe is outgoing. Sensation is normal, coordination is normal, and gait is a spastic gait. So when you look at all these features, of course, a mouthful, what you sort of focus on in terms of localization is that you have a recruitment of upper motor neuron features and lower motor neuron features within the same segments. As an example, when you look at the tongue, there are fasciculations, okay? And it's atrophic, but the jaw jerk is present. When you sort of go into the lower limbs, again, there are features of lower motor neuron as well as features of upper motor neuron. And I think the same with the hand. So this is very useful in terms of formulating localization, and it will help you in terms of what you're supposed to be thinking about. And of course, you always have to remember this chart here, and you can see that there are a number of features that are described in the examination that are overlapping between upper motor neuron and lower motor neuron sort of lesion. So differential diagnosis is really amyotrophic lateral sclerosis, number 1. And then you're thinking of a polyradiculopathy from severe disc disease. And then you're thinking of primary lateral sclerosis. You're thinking of multifocal motor neuropathy and other neurodegenerative diseases. Of course, I should mention that in terms of amyotrophic lateral sclerosis and primary lateral sclerosis, they're sort of, it's almost as if primary lateral sclerosis is sort of within amyotrophic lateral sclerosis or motor neuron disease, if you like. Whereas a polyradiculopathy with severe disc disease is difficult to motivate because it will not explain the bulbar symptoms that are listed in the scenario as well as the findings on examination. So let's just talk about amyotrophic lateral sclerosis. So in terms of epidemiology, so amyotrophic lateral sclerosis or motor neuron disease is sort of 2 forms. There's a sporadic form and there's a genetic form. Of course, their age sort of onset in terms of sporadic, generally around 65 years, and then genetic between 46 and 55 years. And I should mention that, of course, this is not cast in stone. In terms of epidemiology, these could be sort of Western data. There is definitely a difference in the sort of sub-Saharan sort of African data from this in terms of the age group. And unfortunately, there isn't very good data in sub-Saharan Africa, except for potential, I think, from South Africa. So in terms of the genetic form, there are literally two genes that have sort of been heavily linked with motor neuron disease. The first one is the SOD1, and then there's the C9OFF72, which is the other one. And again, these are predominantly in the Caucasian population, more than in the Black population. But what is important to highlight is that C9OFF72, of course, can overlap with other neurodegenerative diseases, among them frontotemporal dementia and Parkinson's disease. So like I mentioned, in terms of epidemiology, there isn't really good data in terms of the incidence in sub-Saharan African population. But in the Western population, about 2 to 3 per 100,000 population, and of course, most common amongst white compared to non-whites, which again is debatable. If you look at, of course, anecdotal data, like even in our setting, okay, generally it tends to be more common in men than in female. In terms of etiology, there are a number of things that are postulated there. Okay, there's a genetic aspect. So the two genes that I highlighted there are not the only ones that are implicated. There are a number of new genes that have sort of recently been discovered. If you look at the sporadic form, of course, you have to look at environmental factors, and potentially there are beliefs about viral etiology that could sort of be propagating this disease process. But there is no clear sort of clear-cut etiological agent that has been widely accepted, except for a number of postulations. So in terms of the clinical presentation, 40% of patients will present with weakness of the upper extremity muscles and 40% with weakness of the lower extremity muscles, with, of course, easy fatigability, cramping, stiffness, and sort of weakness and wasting. Okay, 20% of patients will present with bulbar symptoms. They might have dysphagia, difficulty swallowing, and they might have dysarthria, hoarse voice, and then shortness of breath. They might also have pseudobulbar affect, and then they might have some extraocular sort of movements. They might have blood and bowel function. I mean, usually blood, extraocular sort of movements, bowel and bladder function are usually sort of spared. So literally, when you think of amyotrophic lateral sclerosis or motor neuron disease, generally you're looking at a disease process that, of course, generally tends to present with sort of chronic symptoms. If it's limb involvement, generally you might start off with one limb, sort of being involved over several months to years before involvement of sort of another limb, as well as other limbs over time. Okay. So before talking about sort of diagnosis, it's just important to highlight that when you talk about amyotrophic lateral sclerosis or motor neuron disease, I mean, there are sort of subtypes of disease entities that are sort of thought to exist within this sort of umbrella disease. Of course, the extreme end is amyotrophic lateral sclerosis. Then there's a primary lateral sclerosis, generally, which sort of tends to present with upper motor neuron features predominantly. Then there's progressive muscular atrophy, which generally tends to sort of present with lower motor neuron features. And then there's progressive bulbar palsy, which generally tends to sort of present with bulbar symptoms. So you have to think of those sort of different entities in terms of presentation of this sort of motor neuron disease or amyotrophic lateral sclerosis. So in terms of your diagnosis, you sort of want to look at your CSF and neuroimaging, and generally your CSF will be normal. Your neuroimaging will also be normal. So the problem with amyotrophic lateral sclerosis is that it's a disease of the anterior horn cell, where you get degeneration of the anterior horn cells within the spinal cord. And this is literally where sort of the problem starts from. So you get degeneration of the anterior horn cells, and of course, as a consequence, you get your motor unit sort of becoming dysfunctional, and you lose function of your muscles. So when you do your nerve conduction study, of course, you want to see evidence of axonal sort of axonal injury, and because your anterior horn cell is sort of gone and more than demyelination. And then when you look at your electromyography or your EMG, you want to see evidence of denervation. And this will be acute and chronic denervation in multiple spinal levels. So here you're talking about bulbar evidence of acute and chronic denervation in terms of sort of bulbar, and then your cervical spine, your thoracic spine, and your lumbosacral spine. So you want to be able to sort of look for evidence for you to be able to call it as amyotrophic lateral sclerosis. So diagnosis is usually clinical, and you get recruitment of upper and lower motor neuron lesion features in the sort of different regions that I have talked about. And there are different classifications that help in terms of confirming your diagnosis as whether it's a sort of a definite diagnosis or a probable diagnosis or a possible diagnosis. There are a number of different classifications that are sort of out there in use. The commonest is the modified L-scale sort of classification, which can help in terms of trying to figure out your diagnosis. But there are a few other sort of criteria. Some of them have actually been incorporated, nerve conduction and EMG, as part of your diagnostic criteria. With treatment, motor neuron disease, there is really no cure for motor neuron disease or amyotrophic lateral sclerosis. There are a bunch of drugs in trial. One of them is ribosol, which hasn't really shown much of a benefit, with sort of survival within 2 to 3 months, which is not much if you are to sort of focus on getting a drug that is going to alter the course of events. And then you can focus on symptomatic treatment, if there's spasticity, if there are other sort of problems that the patient has, those can be dealt with. And then there's consideration for a PEG tube, particularly for those with serious dysphagia. This might have to be done early on. And then for those with respiratory symptoms, we can focus on doing non-invasive mechanical ventilation. And then ultimately is palliative care, and prognosis generally is very poor, with death within 3 to 5 years post diagnosis. Of course, in terms of the different sort of stratification I talked about, there might be some differences in terms of when the patient, for instance, would sort of die if patient presents with, let's say, predominantly or purely something like primary lateral sclerosis. They might actually have a longer time course before they die compared to someone with ALS. And similarly, if you look at progressive muscular atrophy and something like progressive bulbar palsy, of course, your time course might actually be within the 3 to 5 year sort of prognosis period list highlighted there. Okay, so this is the end of the presentation. Thank you so much for taking time to listen to this presentation. Thank you.